Hello and welcome to today's webinar for mental health professionals. Not who, but when, assessing imminent suicide risk in patients denying suicidal intent, featuring Dr. Igor Galenker. Would now like to introduce Dr. Galenker. Dr. Galenker is the Director of Research and the Director of Suicide Research and Prevention Laboratory in the Department of Psychiatry at Mount Sinai, Beth Israel. He is a professor of psychiatry at the Icahn School of Medicine in New York City and the founder and director of the Richard and Cynthia Zorinsky Center for Bipolar Disorder. His research interests lie in diagnosis and treatment of acute pre-suicidal mental state, the suicide crisis syndrome, as well as the development and implementation of the modular assessment of risk for imminent suicide. There will now be a brief moment of silence while I pass the presenter role to Dr. Galenker.
Should I start?
Yes.
Okay. Hello, everyone, and thank you for having me here. It's my pleasure to give this webinar to the ADAA audience. The title of the webinar is Not Who But When, Assessing Imminent Suicide Risk in Patients Denying Suicidal Ideation and Intent. And in a nutshell, most of us actually know who is at risk by suicide, for suicide. These are the people who we see in the emergency room, where they come for their mental health problems. They have mental health diagnoses, they have past suicide attempts, but what we don't know is when one of these people will attempt suicide. And that's actually the clinical decision that we need to make all the time. And one of the most difficult decisions, meaning deciding whether somebody is at risk or somebody can go home safely. So what I'm going to be talking about is a framework of how to assess when. So disclosures for my talk is that the research and the work I will be presenting was supported by the American Foundation for Suicide Prevention and National Institute of Mental Health. And I don't have any conflicts or consultants, and I'm not actually a part of paid CME activities. This work was done by a large group of researchers, and this is their names, and we have psychologists, psychiatrists, and research assistants. Most importantly, a lot of patients participated in this, and also a lot of residents and staff of the Mount Sinai mental health system. And a lot of the data that you're going to see and the conclusions that will be made based on that, and actually quite innovative and unusual. So let me start by underscoring the scope of the public health issue. So the suicides in the United States have started rising in 2000. And they were rising by 1% a year until 2006, and then 2% a year until 2016, and 4% in 2017. And in that year, the suicide rate went up by 10% in 1 year in 10 to 24-year-olds, and by 50% in children. Now, 50 to 70% contact health services before in the months prior to their death. We know who are the high risk patients. Most inpatient admissions have these people, and you've seen them many times. Most of the suicide decedents have mental disorder, 90%, or past suicidal attempt, 30%. And the problem is to determine what would be the imminent risk in these high-risk patients. no high-risk classification, which is used administratively, or any of the scales that are being used right now are clinically useful because their positive predictive validity is very low. And the second problem is that in our assessment, the centerpiece of our assessment of suicide risk is self-report of suicidal ideation, meaning the answer to the question, are you planning to hurt yourself? The problem is that 75% of people, at least, do not disclose their suicidal ideation when talking to clinicians. And there are several publications about that, and this is our very recent data. So we're currently doing a clinical study called the MARIS study. And in the course of this study, the patients talk to both a clinician and research assistant within 48 hours from each other. And as you can see in this table, the majority of people, about 2/3 or 3/4, do not report past suicide attempt history to either. But substantial minority, 1/3 approximately, report that they had past suicidal attempt. Of those, 67% report, 67 say it to an assistant, 55% only to clinician, and 200 to both. Now, it means 200 of 71% of those people who have suicide, actually suicidal attempt in the past, reported to both clinicians and research assistants. Now, if you look about on the right column, suicide intent, you will see that 142 told either RA, research assistant, or clinician they had suicidal intent. And of those, 81 said it only to research assistant, and 44 said it only to clinician, and only 16 said it to both. So only 16 or 11.2% of this group were consistent within 48 hours in telling either the clinician or research assistant that they're suicidal. So this will tell you that 90% were not, and that's why you cannot rely on self-reported suicidal ideation as a cornerstone, really, of suicide risk assessment. And that may be one of the reasons that our predictions of who will or will not attempt suicide are actually pretty poor. So this is my personal history and with patients who died by suicide in my clinical practice. Over the years that I worked, I've seen about 32,000 people. Of those, 10,000 had suicidal ideation. 2 people died by suicide, and 9 people died after I saw them, and then they went to see somebody else. So 11 people total. And I remember very clearly what happened to each of them the last time I saw them, and what it was like, and what they said, and what I said. And 2 things are remarkable about that last interaction that I had with them. One is that they were suicidal, and they did not tell me. The second one is that in each case, when I was remembering what happened in that session, I thought something was not right. I sensed something, and I didn't know what that something was. It was never really analyzed, and when I talked to other clinicians, they often said the same feeling. I knew something wasn't right, and yet I didn't know what it was. And finally, neither the patient told me about the intent, nor I told them about my discomfort. So we did not communicate. And so the framework for our research that started about 10 years ago was that we need to know, for us to understand and predict imminent suicidal behavior, we need to understand both acutely suicidal patients and their clinician's state of mind, particularly because we cannot rely on the patient's self-report of suicidal ideation. And this is how this talk that I'm giving right now is going to be constructed. First, we're going to talk about what's happening in the suicidal patient mind. Then we're going to talk about what's happening in the clinician's mind. Then we talk about what prevents them from communicating and how to overcome that. And then at the end, there'll be a framework of how to approach the imminent risk assessment. So let's start with what's happening in the mind of a suicidal patient. In the last 10 years of doing this work, what we looked for and we described was a distinct pre-suicidal mental state, which we called suicide crisis syndrome. It's a syndrome which is similar, let's say, to symptoms of depression or syndrome of panic attack or a syndrome of psychosis. It's a distinct phenotype. As you can see on this slide, which has two graphs. One is the distribution of the suicide crisis syndrome scores, meaning its intensity at admission. And on the right, you see the distribution of the scores at discharge. What you see is that the shape of the curves is quite different, and the peak of the scores, I mean, of who had the scores shifted to the left. It means at admission, a lot of people were high on the scores, and at discharge, very few people. The scores were lower. So it's a very acute state. It shifts very quickly. Our average length of stay is 7 days. For comparison, this is the scores of the state trait anxiety inventory STAI, and it's a trait score. And you can see that the curve is exactly the same. It didn't shift. And this is a state, meaning acute anxiety. And as you see, it shifted a little bit, but not nearly as much as suicide crisis syndrome. So this state is actually much more short-lived than state of acute anxiety. And that could be, for instance, one of the reasons why the disclosure to research assistants and clinicians is discordant, because the state may have passed, but there may be other reasons also. So let me describe the diagnostic criteria for the suicide crisis syndrome. We have created actually a checklist that would allow a clinician to interview and determine the presence of the syndrome. And we propose these criteria for a DSM diagnosis, which at the moment, as you know, DSM does not have a suicide-specific category or diagnosis of mental state, which I think is badly needed. So the most common and most important symptom of the suicide crisis syndrome is what we call ruminative flooding or entrapment, which is a more commonly used term. When the patient presents with a problem that they perceive as intolerable and unsolvable, they may describe themselves as being trapped, having no exit, having reached a dead end. It doesn't mean it that way, but this is how they see it. And one of the patients described it to me like that. He said, imagine you're in a department store full of people, and suddenly the lights go out. Then a minute passes, the lights go on and they go out again. But you see that there's nobody in the store. And you want to run out, and you run to the door, and all the doors are locked. So that's ruminative flooding on entrapment. I'm sorry, actually that's misnomer, it's frantic hopelessness. My apologies. Should be called frantic hopelessness. And then there are 4 associated disturbances that also need to be present in addition to frantic hopelessness for the syndrome to be complete. One is affective disturbance, and it is either emotional pain or rapid spikes in negative emotion or extreme mood swings, extreme anxiety that may be accompanied by dissociation, sensory disturbances, and acute anhedonia, meaning inability to feel pleasure. Chronic anhedonia is not associated with imminent suicide risk, but acute anhedonia in somebody who was able to feel good about life and now nothing tastes good or feels good is. The second component is loss of cognitive control. And it's manifested by intense and persistent ruminations about one's own distress and the life events that brought on this distress. And people describe it as being kind of going down a rabbit hole or being sucked into a vortex, and they can't climb out of. Inability to deviate from these repetitive and negative pattern of thought, which is cognitive rigidity. An experience of overwhelming profusion of thoughts that can give them headache and somatic symptoms like head pain. And in extreme cases, people feel their head can explode. And when they try to suppress these thoughts, they fail, and the thoughts come back with a vengeance. The third criterion, B, is disturbance and arousal. Okay, which is agitation, hypervigilance, irritability, and global insomnia. Most suicides and suicide attempts take place at night because people can't sleep when they lose cognitive control and they think these repetitive thoughts and feel terrible and are flooded by them. And finally, the fourth component in criterion B is social withdrawal. And this is gradually withdrawing from friends and having evasive communication as opposed to direct communication, with them being kind of vague. Importantly, the suicidal ideation may or may not be present. It's obviously not an exclusion criteria, but it's not an inclusion criteria either, because as I mentioned to you, 75% of people do not report it, and it could be short-lived, and although when it's there, it does not certainly decrease and likely increases suicide risk, it is not a must. It's just one of the symptoms. This is our paper, which was just published on network, what's called network analysis of the suicide crisis syndrome, and the paper shows that it is actually a very coherent syndrome. As you see in this graphic, all the circles which represent various symptoms are close together, and actually they separate cleanly into the 5 syndrome clusters that I described to you, which is entrapment. This would be social withdrawal and anhedonia, and that would be the ruminative flooding, and the insomnia, irritability, and finally social withdrawal. If this was not a coherent syndrome, that you would see these clusters all over the place, these circles, and not being closely connected. So this finding, meaning the syndrome being a single syndrome, has been replicated 4 times, and now in different countries. I'm going to come back to the suicide crisis syndrome and how to interview for it at the end, but let me come back for a second. But basically, if you have 1 minute to ask a question, the most important critical questions of a patient that you see in the emergency room or in your office, it would be something like this. This problem that you told me about right now, that is really make it painful for you to leave. When you think about this, can you control your thoughts, or do you feel like the thoughts control you? And if the answer is that the thoughts control me, that's actually a symptom of ruminative flooding, particularly if the thoughts give somebody a headache or oppression in their head. And then the second question would be, and do these happen at night? And if the answer is yes, do they prevent you from sleeping? And that's also the second part of the syndrome. And finally, when you think about this, do you feel trapped? Are there solutions? To your situation? Is there a way out? And if a person does not see a way out, then the risk of imminent suicide actually goes up significantly. So With that, let's go to the second part of the assessment, which is what's happening in clinician's mind. Now, when you see a suicidal patient in your office, they're usually in distress, they have ruminative flooding, they have emotional pain, they feel trapped, and have a lot of this torment and negative emotion that they plan to share with you. And when they do that, what do they think about you, the clinician? Probably not very much, but if they do, they think that whatever you have there is very calm and it's not going to affect them, and you're managing it pretty well. So what's happening in reality? What happened in reality is actually that you may not be feeling so calm, and what people do in reality, clinicians, is they feel a lot of negative emotions. They feel anxious, they feel threatened, they sometimes feel scared and insecure in their ability to assess the patient. But something actually may happen even more specific. So let me play out an imaginary interaction with a suicidal patient for you. So the patient comes in and they've seen many doctors previously. They come to see you as a psychiatrist, and obviously they hope that you will help them, otherwise they wouldn't be here. So the first thing that they often do is that idealize you. The patient idealizes you, think they would help them. And how would that make you feel if you have a patient who tells you, doctor, I really want to help you. I want you to help me, and I believe you would. And you would feel hopeful. So if you would feel hopeful, the patient would see that, and most likely they will test you. Are you really different? Are you the same like everybody else? Are you here for 15 minutes and just can't wait for them to leave the room so you can see the next patient? So they're going to test you. They're going to call you after hours. They're going to come late. They may call you on the weekend. And what you're going to do in response if you're a good clinician? You're going to respond. You're going to do something which could be out of character for you. You would answer a phone call after hours. You may actually stay late to see them. You may even come in, not right now during COVID epidemic, but you would have an extra session in the evening. And what is that called? That's called over-involvement, when you actually go beyond what would be a usual professional stance. And and how would the patient respond to that? Because it will not be enough, because you, as many other doctors before, or several other doctors before, who also cared, also tried to do something like that. And actually, it did not save them. It did not help them because their pain and their life situation is very difficult. And so the patient would try to devalue you. They would say, Doc, you really can't help me. I mean, you're no different from everybody else. And generally, where are your degrees from? And where is your accent from? And that probably would make you feel angry. And as a good clinician, you'll try to contain that anger, but patients sense it. And they watch us very carefully and watch our demeanor. And in response to this anger that we're trying to conceal, they may feel hostile. And then we'll dread seeing that patient. And that would be seen and perceived as a rejection. So this is not a typical interaction that I made up that happens when you start assessing somebody and treating them who is acutely suicidal or can be suicidal. But as you can see, there's actually two sets of emotions here. In the beginning, you'll see hopefulness and some positive emotions, especially initially in the treatment. And then on the bottom, you'll see a second box that has a lot of negative emotions, which are also very complicated. And so what we discovered in a series of studies that clinicians have experienced three emotions, which are actually diagnostic of a patient's acute suicide risk and imminent suicide risk. And when clinician feels that, and I'm going to describe these three emotions, most likely the patient is at higher risk than you would normally think. So the first one is simple distress. You feel the patient makes you feel distressed and makes you feel uncomfortable with whatever story that they're telling you. The second one is a paradoxical mixture of hope and distress, because if you're hopeful for the patient, why would you feel distressed? You should feel calm, and yet you feel distress. We call that mixture of emotions anxious over-involvement. It's a contradictory emotion, and it's kind of close to countertransference love over positive countertransference. And the second emotion is another paradoxical emotion, which is a combination of hopelessness and calm. You feel that there's nothing you can do for that person. I mean, that no matter what's going to happen, they're going to kill themselves one day. But somehow it does not distress you. And that emotion we call collusion avoidance or distancing, and it's similar to denial. Now, we as clinicians are trained not to feel this, but these actually emotions are diagnostic of imminent suicide risk. So actually what we need to do as clinicians, we need to learn how to feel them, identify them in ourselves, and also use them clinically and manage our own response to these emotions. I'm not going to go too deeply into this, but that's a very important part of clinician training that we're working on right now. So now we have an idea what's happening in a patient's mind, which is a suicide crisis syndrome, and what's happening in the clinician's mind, and this is uncomfortable, conflicting emotional response. So how can we put these together in assessing imminent suicide risk? So what we did is that we used a multi-informant approach to the assessment that we called MARIS, multi-informant approach to the assessment of imminent suicide risk. So the basis for this is that whenever you have several independent sources giving you information about an event, then this information is more powerfully connected with that event or phenomenon than the same information from a single source. And because what you have when you have several sources is that you assess each source separately, you assess informants separately, but you also assess the difference between source and informant. So this approach used routinely and in assessment of children and adolescents because they don't have, they're not emancipated, and so you need an opinion of the parents. But you still talk to the adolescent patient, you talk to the parent, and then you assess information from both and the difference between them. For instance, it is very well known that parents of adolescent children substantially overestimate their depression and underestimate their suicide risk. So we use the same approach, except in addition to the patient who is informant number one, the second informant is you, the clinician, or me as a clinician. So we created a scale that has 4 models from 2 informants, the two clinician models and 2 patient models. And the clinician models, the patient models assess the intensity of suicide crisis syndrome and also their opinion of suicide as an option. So SCISF, Suicide Crisis Inventory, on the top left is the intensity of suicide crisis syndrome. On the bottom, in the opinion whether suicide is an option when life problems become intractable. And on the right, you have a clinician models. One is explicit assessment of the risk, and such as have you had a suicide attempt, do you have a mental illness, and TRQSF is a scale for therapist response questionnaire, short form, and that's your emotional response to the patient. As these are called ROC curves, and the way to assess how effective some a particular phenomenon is, or how significant, you assess the area between the green line and the blue line on top of each curve. The green line is pure chance. It's 50-50, higher or lower than the green line. And the area between the blue line and the green line tells you how effective the prediction is. And as you see here, the lines are actually pretty close, and only one of them reaches statistical significance, which is actually clinicians' emotional responses. However, if you add these together, the predictive validity of the scale increases dramatically and gives you sensitivity and specificity of 0.7 and 0.9, and the odds ratio of predicting the suicidal behavior corrective of 19. Now, this is already clinically significant and can be helpful, not necessarily as a scale, although also as a scale, but as something that would inform your clinical judgment. So that was our first study, and just now we replicated this study in a different group, which was a mixed group of outpatient actually in inpatients, primarily outpatients, and 115 clinicians. The inpatients were admitted with suicidal ideation and suicidal intent. The outpatients would be at moderate risk for suicide because they were outpatient, and everybody was evaluated within 72 hours of intake. Subjects were reached within 4 to 6 weeks of follow-up. 12 of them had suicidal behavior, and about 40 had suicidal ideation. And what we discovered in the replication study is that the scale is even better than we thought, because only just two models are sufficient to predict suicidal behavior. One is the patient model, the assessment of suicide crisis syndrome, and the other one, the clinician model, the assessment of clinician's emotional response. So the scale is named MARIS-2, and it is being actually, validation has been published, and predictive validity we're assessing right now. But here is preliminary data on the predictive validity. As you see, SCS is actually the suicide crisis syndrome intensity, has an odds ratio of predicting suicidal behavior of 5, and so does clinicians' emotional responses, which is TRQ-SF, also have a predictive validity odds ratio about 5. However, if you have either suicide crisis syndrome or clinician's emotional response, the replicated predictive validity odds ratio goes to 16, which is very similar to our original ratio of 19. So this finding has now been replicated in a Norwegian sample, German sample, and an Israeli sample. I don't have the data to show you yet, but it's now been replicated in different cultures. The only other risk factor that has incremental predictive validity at 1 month's follow-up is lifetime peak suicidal ideation. Not current or past month, because as you saw, I mean, people are not disclosing it. The patients are not disclosing it, either to clinicians or research assistants, for all kinds of reasons, primarily out of fear of not being released from the hospital. But they're much more forthcoming about lifetime suicidal ideation, because it may not be necessarily as threatening, and it's a more reliable predictor. So coming back to our framework, now we have suicide crisis syndrome in the mind of suicidal patient and conflicting emotional responses in the mind of clinician. And we have a scale which is MARIS-2 that can assess them both synergistically, and the scale takes, by the way, a minute to administer. 2 minutes at most, but no more than that. So I don't know if you picked up on that in the previous slide, but there was little correlation between the suicide crisis syndrome intensity and clinicians' emotional responses. And that's a little bit puzzling. If we are so nervous and distressed about a patient being suicidal, wouldn't that be a relationship between our distress and the intensity of the syndrome that is predictive of imminent suicidal behavior? So, and yet that's not the case. So that made us investigate what actually we respond to. What makes us uncomfortable, distress about the patient that we're assessing. And for that, we used our model for suicidal behavior, which is called narrative crisis model. Let me go over the model on the next slide. It's actually very intuitive and simple as a framework. Generally, some people have trait vulnerabilities or long-term risk factors for suicide, long-term. And it's things that we know, like history of mental illness, past suicide attempt, impulsivity, hopelessness, perfectionism, fearlessness, and cultural acceptability of suicide. Of all of these, by the way, it is perfectionism that is the most important. And impulsivity actually is not particularly important, although we tend to think about it that way, because most of the suicide attempts actually premeditated to some degree and result from the intense suicidal crisis. So some people with trait vulnerability, when they have stressful life events, like for instance we're having right now with COVID epidemic, or some other related stressful life events, like such as a final romantic rejection, loss of job, loss of home, quarantine would be the case, loss of social connections with loved ones. When they encounter these stressful life events, some people, and those who have trait vulnerability, they develop a particular picture of their life that we call suicidal narrative. And it's part of the theory of what we call narrative identity that posits that all of us have what we call life narrative. And it's a fairly coherent picture of our life as a story, where we come from, what our past was like, what our present is like, and where we're going, and in the future. The typical suicidal narrative, which does not necessarily reflect the reality and often does not, and it's actually cognitive distortion, has the following story, a life story, is that somebody had a life goal, which is usually unrealistic because a person has perfectionistic tendencies. And it could be either career goal of, let's say, become a doctor, make your first million when you're 16, or a relationship such as a happy marriage, American dream, home with 2 children by a particular time in their lives. And what they feel strongly is that only achieving that goal would make them happy, and not achieving that goal is unacceptable. And because the goal isn't realistic, that person feels that they fall short of that goal. And that makes them feel defeated. And they cannot disengage from that goal. Like a person who, like one of the patients that I had, both of his parents were English professors. And he was the only child. And he grew up thinking that and believing that the only fulfillment he's going to have is being an English professor. And he couldn't, because he had a bipolar disorder and his cognitive function was not the same. And but he couldn't redirect himself either, let's say, to be an English teacher in high school, which he could manage. And unfortunately, that life story resulted in a suicide because he couldn't cope with that. So he felt defeated. And people like that person also feel humiliated because they lost, they're not able to fulfill their goal. And then they feel that they become dependent on other people because often there's a financial repercussions for what happens, or emotional repercussions. And they often feel burdensome because the adult, they should be self-sufficient. And that is incredibly painful and humiliating situation. When they look into the future, they cannot see anything. There's no future because the future that they pictured initially that would make them happy is not happening. So that's suicidal narrative. You have no future, and it's a cognitive picture. So trait vulnerability is a kind of chronic state. It's always there. It's actually a trait. And chronic suicide risk and suicidal narrative is a subacute state. It can last days, weeks. And when somebody has suicidal narrative that I described to you, what they can develop is acute negative affective state that we call suicide crisis syndrome. And this is what I just described to you. And it's feeling trapped, of having no future, having frantic hopelessness, trying to escape, and escape is not possible. Having ruminative flooding, when you cannot stop your thoughts about this, and your thoughts and you're controlled by your thoughts. Loss of cognitive control, affective disturbance, which is an emotional pain, and also the over-arousal and social isolation. And when people have this syndrome, which is very acute and painful, in that state, when they have suicidal narrative, they actually are at risk of imminent suicide. So this is our narrative crisis model, and I'm going to come back to it later, but for the time being, we used it to test which part of this story, which part of this model, we clinicians respond. What is it gets to us that makes us feel these feelings that are diagnostic of suicidal behavior. And so before we go there, just the last word about narrative crisis model of suicide. There are many other models of suicidal behavior. There is motivational volitional model and stress diathesis model, an interpersonal model, and three-step model. So what differs our model from others is that actually we distinguish between long-term and short-term risks. And we do not include suicidal ideation as a risk factor. Suicidal ideation behavior is actually outcome. Because suicidal ideation, as some research shows, can last 15 minutes or not at all. And yet we need to know who is at risk for suicide before that, even before that happens. And again, many suicidal patients do not disclose their suicidal ideation or intent, so we cannot rely on that. And we also have a suicide-specific syndrome, which has particular criteria and actually would have biological underpinnings that can be described and diagnosed and treated. Because it's a biological syndrome, it can be treated with medications. And we also include this life story of suicidal narrative. Let me skip this slide, I already described it. So what we did is that we assessed the relationship between clinicians' emotional responses that I described to you in the three components of the narrative crisis model: the long-term risk factors, the suicidal narrative, and the trait vulnerabilities. And what we discovered is that actually we do not respond to long-term risk factors, such as impulsivity, perfectionism, pessimism. And we don't respond to the suicide crisis syndrome necessarily for some reason, which is the entrapment and ruminative flooding and social isolation. But what we do respond is to the narrative, to the patient's story. And that's what makes us uncomfortable, and that response is diagnostic of imminent suicide risk. And the finding was actually quite significant. And so then we looked at the components of long-term factors and suicide crisis syndrome and the narrative, and we discovered there was no responses to individual components of trait vulnerabilities as expected. There was no response to suicide crisis syndrome, somewhat unexpectedly, and there were responses to several components of suicidal narrative, particularly burdensomeness and fear of humiliation and actually goal re-engagement, meaning inability to pursue, to change direction if you are from the goal that you thought when you achieve it would make you happy. So, so what does it mean? Let me come back. So why is it that we respond to the narrative and not respond to the crisis? And the two possibilities of why we don't respond to the crisis, and we have to figure that out. One is that some inexperienced clinicians may not see the crisis as such and may miss it, while they would see the life story, and it is easier to respond to the coherent life story. It makes us scared because we can relate to that. We have our own life stories. And the other one is that the opposite is that we numb ourselves to suicide crisis syndrome because as doctors, we're trained not to feel. And actually, there's a lot of studies that show that our empathy decreases with our experience, although not necessarily clinical judgment. So, but that is remain to be explored. So moving forward, how do we use what I just described in clinical practice? Because, as I mentioned before, the clinical scales do not have appreciable clinical validity. Because even in our scales, the positive predictive value was only about 10%. And with that, we are going to lose a lot of people. So there are several studies that show, including one of ours, that the best predictor remains our clinical judgment, meaning on a scale of 1 to 10, how likely is the person to die by suicide, commit suicide, kill himself in the next, let's say, several weeks. And that turned out to be actually working better than most scales. Well, actually all scales with the exception of one report. So let's look at our clinical judgment. So what goes into our clinical judgment? And it turns out it has actually two components. One is rational thinking, which is our assessment of the patient history, mental status examination, our knowledge of psychiatry, and various questions that we ask and integrate. But there's also our emotional response, which is a gut feeling. And now we know what it is. And it is distress and combinations of hope and affiliation in a paradoxical way. And it turns out that when you do the analysis, neither of those alone is a predictor of near-term suicidal behavior, which in all our studies is within 4 and 8 weeks. However, if you use clinician judgment as mediator, okay, then both of them go in the clinician judgment that mediates the assessment of the suicide risk in about actually equal measure. So the two components of our clinical judgment, the rational assessment of risk using our knowledge and what we learned, as well as our emotional response, are critical, and they're both important. And this is yet another evidence that we must pay attention to what we feel about the patients. We must train ourselves to be able to feel what we feel, as opposed to suppress that and ignore it, and also to manage these emotions effectively when interacting with suicidal patients. So in conclusion, before we go to the, again, to the narrative crisis model, let me summarize what we learned. So Mary's approach, which is model assessment of risk for imminent suicide, is a valid approach. We actually established it in the first paper and then generalized using Mary's 2 and replicated it. And that approach includes the clinician component and the patient component. We established a new suicide-specific diagnosis, suicide crisis syndrome, which is a stable construct, was replicated several times in diverse countries, cultures, and clinical settings. And we're working on actual application of suicide crisis syndrome for actually DSM Committee on Diagnosis. And we established clinicians' emotional responses to suicidal narrative, which confirm that they could be used clinically, but also confirm the concept of suicidal narrative. As you may know, some of the most effective treatment for suicide prevention, which are CAMS, David Jobs treatment, and ASIP from Conrad Michel, include narrative assessment of the patient and assessing patient's life story and trying then to change the life story. So if you think about the way we take history right now, particularly with the electronic medical records, where all of it or most of it is drop-down menus and checklists, which fragment the life story, it's actually, in my opinion, worsens our ability or impedes our ability to hear the life story and assess suicide risk. And I think we need to move away from drop-down menus and suicide risk assessment. And the other thing is that, again, multi-informant methods are better than single informant methods in assessing the risk. So coming back at the end of the talk to the empirical support for narrative crisis model of suicide, is there such model, so such support? And actually we have two studies to support that. Study 3, which is inpatient, outpatient sample, and it includes stressful life events. It has 2 time points. One is the assessment of the mental state, and the other one, the future suicidal behaviors. So there is no temporal resolution between different components here. But study 4 has 3 time points. There is intake, inpatient admission intake, then discharge, and then future suicidal behavior. So that one has 3 components and actually has resolution, temporal resolution, which can tell us what's what and what comes first. So study 3 has a mixed sample and pretty large sample, 1,058 patients, 328 inpatients, 730 outpatients, 696 at 1 month's follow-up. Not all subjects completed all the tests. And so this is a more schematic representation of the narrative crisis model that does not include the details. So we have trait vulnerabilities, TV, stressful life events, suicidal narrative, suicidal crisis, and suicidal behavior. And what we assessed, and we conducted actually regression analysis to see if this model works and predicts suicidal behavior. And suicidal narrative is like a cognitive construct, and suicide crisis syndrome is more an affective construct. We used stressful life event measures that we developed, trait vulnerability measures that other people used, our own suicide crisis inventory, suicide narrative inventory, and Columbia suicide severity rating scale. And we conducted mixed mediation duration analysis, which is pretty complicated but widely used software. Participants had multiple diagnoses, and primary was depression. Okay, and some had no diagnosis, some had personality disorders. And so, to make the long story short, the model was significant and highly significant. So these components that I described to you, trait vulnerability, stressful life events, suicidal narrative, suicidal crisis, predict suicidal behavior within a month when in that sequence. The only thing which could not resolve is whether suicidal narrative comes first and then gives this pessimistic and distorted life narrative creates or results in suicide crisis syndrome, or it's your negative state of mind that makes you view your life as suicidal narrative. So this study, we couldn't resolve. However, in study 4, our suicidal narrative was obtained with trait vulnerabilities and admission, while suicide crisis syndrome was obtained at discharge. And in this case, we used the structural equation modeling analysis, which is more sophisticated, to, again, assess whether the model works. And we used only inpatient, sample size is smaller, and we did not assess stressful life events. And as you see here, it's a pretty complicated model that assesses the interaction of all these factors. And to make the long story short, the model was supported and no alternative pathways were found. Actually, interpersonal component of narrative, meaning the defeat, humiliation, isolation, no future component, turned out to be more important than goal orientation, meaning disengaging from the unreachable goal. But that's the only thing that did not work 100%. But that probably is due to, we think, the scales that we used may not have been the best scales. So these are the first prospective study to assess full multi-stage model of suicidality. Prospective with prediction of future behavior. And it actually provided temporal resolution of the model and supports our contention that it's the narrative that gives rise to the suicide crisis syndrome. So let's come back in a conclusion to the narrative crisis model of suicide, which we find exceedingly useful framework in assessing and treating and preventing suicide. We use the model backwards, from the most acute predictor of suicidal behavior, which is the suicide crisis syndrome, to a more long-term, which is trait vulnerability or long-term factors. So first, we need to assess the suicide crisis syndrome, and I described to you how to assess that with quick, actually summing it up into 3-4 questions, which is, does your current life situation makes you feel painfully trapped? Can you stop thinking about it, or the thoughts control you? Does it happen at night? These, in a nutshell, is the most important questions that you need to ask there, although there are also, of course, several others. And if that happens, if the answer to all these questions is yes, and particularly the loss of cognitive control and emotional pain, this syndrome, we contend, needs to be treated with medications before you can have rational therapy of any modality aimed at restructuring suicidal narrative and changing your coping skills and trait vulnerability. And we have preliminary data that this suicide crisis syndrome can be treated with some of the antipsychotics and benzodiazepines and result in decrease of future suicidal behavior. We're in fact working on this paper right now. But what's critical, and many people know that, when somebody has this rigid thinking that the woman rejected me, the love of my wife rejected me, and that's why, I'm not, my life is not worth living, and I'm not worth living because I'm, a piece of garbage, or I could not become a doctor, and I betrayed my family and their trust, and my life is not worth living. Once a person cannot derive from those thoughts, you cannot do therapy, and that needs to be treated with medications. So once that is treated, then you use acid or CAMS or similar therapy to restructure suicidal narrative and try to untrap the person who feels trapped. But it's not going to work until you treat the syndrome. Once that is treated, then you can work on long-term vulnerabilities, which may make a person prone to the next syndrome during the next crisis with stressful life events. And that's long-term therapy on self-acceptance, self-compassion, and decreasing impulsivity, which could be similar to DBT, for instance. And then you can also work on coping skills when people faced with stressful life events. And finally, not to be forgotten, the most effective actually prevention, which is means restriction, such as in the United States would be guns, accessibility to firearms, which are used in 51% of suicides, and it's the only country in the world where firearms are used. So I suggest that you try to use this model. We find it exceedingly useful and user-friendly. So our future direction in this research is that we would like to implement a narrative crisis model as a framework for suicide risk reduction and suicide prevention treatments. And I get emails from people who start using it that it's a very helpful framework together with the clinicians' emotional responses. And again, it's intuitive and simple to use. We do need to now, together with Thomas Joyner, who also had similar work on acute suicidal affective disturbance, to submit an application for new DSM category. MARIS, which is MARIS 2, a simpler version, a 1-minute version, I think will need to be implemented. We're working on that. And finally, it is critical to educate clinicians in emotional self-awareness and empathic communication while being emotionally self-aware and being able to use your emotional responses to suicidal patients clinically, because they're 50% of prediction. The 50% of your clinical judgment is that, and you cannot ignore it. And we must train clinicians, administrators, and lay persons. So most of the framework that I just talked about is described in my book, The Suicidal Crisis. It's 2017, and at that time, we only have experimental support for half of what is described in the book. But since then, everything that I talked about is now evidence-based and experimentally supported. And the reason it works is because it derives from clinical experience. So the book is available on Amazon. Invite you to buy it if you are interested reading about it in more detail. There's 70 cases described there. And thank you for your attention.
Thank you very much, Dr. Gallenker.
You're welcome. My pleasure.
For those of you who purchased continuing education credits for this webinar, you will receive an evaluation link in your registration confirmation email. You must complete the webinar survey and post-test questions to receive a CE/CME certificate. Please email us at webinars@adaa.org if you don't receive this link. If you are not yet an ADAA member, we invite you to view the many membership benefits that ADAA has to offer. ADAA members enjoy year-long access to continuing education programs, free access to special interest groups, including online peer consultation groups, promotion of your practice in ADAA's online Find a Therapist database, significant discounts to ADAA's annual conference, and much more. We would also like to invite you to check out more ADAA on-demand webinars by visiting our website, www.adaa.org. On behalf of ADAA and our presenter, we thank you for joining us today.